I am going to give you a broad outline how to manage a patient of PCOS when she comes to you with infertility. But first, let us know what this PCOS is all about. I know we all are very well aware that it is a genetic, hormone, metabolic, and reproductive disorder that affects women, and it is the leading cause of female infertility. It can lead to lifelong complications. That is my last slide, because that is also very, very important, because we have to understand the long sequelae along with the psychosexual function which gets affected because of PCOS in the form of anxiety, depression, and their sexual life. So it affects 1 in 10 women. 10 to 15% of women are estimated to have PCOS. 50% of these women, they remain undiagnosed. 50% women with PCOS who will develop type 2 diabetes before the age of 40 years. This should be known to each and every gynecologist. 13.8 billion is the estimated annual cost. Of course, this is the American statistics, and there is 3 times increased risk of developing endometrial cancer if this woman is having PCOS. We all are aware about the common signs and symptoms with which these patients come to our OPD. Coming to the infertility, remember it is the biggest cause of infertility in women, but at the same time, not all women with PCOS, they will experience infertility. However, it remains the primary cause of anovulatory infertility. So these are the main reasons, causes of female fertility, and you can see ovulatory disorders constitutes to the 40% of the causes for female fertility. And in this ovulatory disorder, PCO is the etiological factor for 85% cases of ovulatory dysfunction. PCOS, it is one condition where people always like to agree to disagree. Over the years, these disagreements have continued. Criteria for diagnosis keeps on changing. Management guidelines also keep on changing. So I will be covering the diagnosis, the lifestyle interventions, first line management, second line management, and third line management of infertility in these cases of PCOS. Now, these are the criteria we all are very well aware of, like NIH criteria, the Rotterdam criteria 2003, and the criteria given by Androgen Access Society. Now, currently, what we are following is the guidelines given to us by International Evidence-Based Guidelines for the Assessment and Management of Polycystic Ovarian Syndrome, released in ISHRE conference way back in 2018. What is the difference? Not much of a difference. These guidelines endorse the Rotterdam PCO diagnostic criteria in adults. That is, 2 of the clinical or biochemical hyperandrogenism, ovulatory dysfunction, or polycystic ovaries on ultrasound. Difference is where irregular menstrual cycles and hyperandrogenism are present. These guidelines are highlighting that ultrasound is not necessary in diagnosis. But this is for those women who have not come to us for infertility, because for infertility anyway we are doing a day 2 transvaginal scan. This is mainly for the adolescent PCOS. And for the adolescent PCOS also, within 8 years of menarche, both hyperandrogenism and ovulatory dysfunction are required, and ultrasound is here not mandatory. However, in these guidelines, ultrasound criteria have been tightened with advancing technology, and they are saying that AMH levels are not yet adequate for diagnosis, again, more so in the context of adolescent PCOS, because for infertility cases, we are going ahead and doing anti-Mullerian hormone for these patients. So what are the ultrasound criteria which has been given in these guidelines? They have mentioned that you have to do ultrasound with an endovaginal ultrasound with a frequency bandwidth of 8 megahertz. The threshold for PCM should be on either ovary, a follicle number per ovary of equal to or more than 20. And or an ovarian volume of more than or equal to 10 ml, ensuring that you are not including corpora lutea, cyst or dominant follicles in your measurement. So this ovarian volume is more important in cases of adolescent populations where we are reluctant to do a transvaginal ultrasound. If you are using the older technology, the threshold for PCOM could be an ovarian volume of more than or equal to 10 ml on either ovary. So just remember these ultrasound criteria. Guidelines have also highlighted the protocol for reporting the follicle number when we are doing our transvaginal ultrasound. We have to mention all these points in our report. Now, what not should be done? We no more do LH levels, LH-FSH ratio. Fasting insulin is also not sensitive, and we don't use dexamethasone therapy because it can induce insulin resistance. So now coming to the management. If she has come to you with oligomenorrhea and infertility, of course, you have to exclude all other etiologies. If you are sure that she is having PCOS, you have to screen for diabetes and you have to intervene if the HbA1c is more than 6.5, that is the cutoff. You have to consider metformin if HbA1c levels are elevated. I have already told you the cutoff is 6.5. You have to also screen these women for hyperlipidemia and hypothyroidism. Remember the cutoff of TSH here is 2.5. Again, the second most important point here is optimizing lifestyle and grab this opportunity for routine prenatal counseling and vaccination. If obese woman with PCOS is coming to you, then weight loss, I will highlight how you should advise her. If BMI is more than 27, then you have to consider weight loss in your strategy. Routine infertility evaluation should be conducted. You have to evaluate her for tubal patency. You have to evaluate the endometrium and don't forget to evaluate the male factors as well. If then you come to a conclusion that she is having infertility because of oligo-ovulation, then you have to initiate with your ovulation induction. So this is the algorithm which will come as a ready reckoner in your day-to-day practice. Now there are other factors which affects fertility, your treatment response or pregnancy outcome. And what are these factors? Just to give you some examples, like you have to do blood glucose, weight of the patient, blood pressure, ask history of smoking, alcohol, ask history of diet, exercise, more so if she is an obese, about her sleep pattern and mental health, about her emotional and sexual health, because all these things have to be optimized so that you can have a good outcome as far as the reproductive and obstetric outcomes are concerned. So once you start, you are there with your diagnosis of oligonovulation. These guidelines are emphasizing more and more on lifestyle intervention. So you can see in this chart that the first line, non-pharmacological management for infertility in PCOS is lifestyle management. Then the first line, pharmacological management, is in the form of letrozole, clomiphene citrate, clomiphene plus metformin, metformin alone, and gonadotropins. Second line, pharmacological oblique surgical I have written because second line therapy can be in the form of gonadotropins or laparoscopic ovarian drilling. And the third line management is your ART, that is IVF ICSI. So now let us start. What do we mean by lifestyle interventions? Because everybody is saying lifestyle, lifestyle, lifestyle. So what do we mean actually? So lifestyle interventions include behavioral strategies, dietary intervention, exercise intervention, and obesity and weight assessment. So what should be the goal setting for weight loss? I know it is very easy for us to tell the patient that go and lose your weight, but we have to guide her how to lose that weight. So for this, you have to give her a SMART goal. And what is this SMART goal? It has to be specific, measurable, achievable, realistic, and timely. So what is the SMART goal? That is 5 to 10% of weight loss in those patients who are obese is considered as successful weight reduction, and this has to be reduced within 6 months. So this should be the SMART goal for weight loss for your PCO patient, that is 5 to 10% of total weight loss in 6 months of time. Now, how to lose weight is the next question. Here comes the role of diet and exercise. Now the internet is flooded with so many types of diet plans. So now the patient is asking you, doctor, which diet plan is best for me and how much calorie deficit you will prescribe for me. So I know if it is suitable to you, if it is convenient, involve a dietitian to prepare a dietary chart for them. But if you are in a remote place or you don't have that facility, then in a nutshell, you have to guide these women about the dietary intervention as well. So what is this dietary intervention? First and foremost, tell her that no dietary type is recommended in PCOS. She should not go on the net and follow those dietary patterns. To achieve weight loss in those who are having excess weight, an energy deficit of 30%, that is 500 to 750 kilocalorie per day, could be prescribed for women, but you have to consider the individual energy requirements, her body weight, her food preferences, and physical activity level. So it has to be an individualized approach. Now, from diet, because diet alone is not going to help her in weight loss, it has to be combined with exercise. So how much exercise for mild weight loss and how much exercise for moderate exercise? And of course, not this kind of exercise which everyone is fond of doing in front of TV. So now again, you have to give her a goal for physical activity. Again, it has to be a SMART goal. So what is this SMART goal? Again, specific, measurable, attainable, relevant, and time-bound goal. So this goal could include 10-minute bouts, progressively increasing physical activity by 5% weekly, up to and above the recommendations what you are giving her, recommending for that particular woman. In those women, a minimum of 150 minutes per week of moderate intensity physical activity. These are all given in guidelines, or 75 minutes per week of vigorous intensities, or an equivalent combination of both, including muscle strengthening activities on 2 non-consecutive days per week. This is for mild weight loss. And activity should be performed in at least 10 minutes bouts or around 1000 steps, aiming to achieve at least 30 minutes daily on most days. But what about moderate weight loss? For moderate weight loss, a minimum of 250 minutes per week of moderate intensity activities, or 150 minutes per week of vigorous intensity, or an equivalent combination of both. And this has to be combined with muscle strengthening activities involving major muscle groups on 2 non-consecutive days per week, and minimize your sedentary screen or sitting time. Of course, when it comes to moderate weight loss, you have to take the help of a gym instructor and of course a dietitian as well. Is there any role of anti-obesity agents? Because a lot of patients, they are looking for a shortcut. They will tell you, doctor, please prescribe a pill so that I can lose weight faster. So what is the recommendation by these guidelines? Pharmacological anti-obesity agents, they could be considered an experimental therapy in women with PCOS for the purpose of improving fertility, with risk to benefit ratios currently too uncertain to advocate these as a fertility therapy. So these are the guidelines as far as the role of anti-obesity agents are concerned. Is there any role of bariatric surgery for these very obese women who come to you for PCOS? Remember, bariatric surgery again is considered as an experimental therapy in these women with PCOS for the purpose of having healthy baby. Again, with risk to benefit ratios currently too uncertain to advocate this as a fertility therapy. So no shortcut. She has to go for diet and exercise. But if at all bariatric surgery you feel that is needed, you have to consider the following points. You have to recommend her to avoid pregnancy during periods of rapid weight loss and for at least 12 months after bariatric surgery with appropriate contraception. If pregnancy occurs, awareness and preventive management of pre and post-operative nutritional deficiencies is very, very important, ideally in a specialist interdisciplinary care setting. And monitoring of fetal growth during pregnancy has to be very, very stringent. Is there any role of inositol in this type of woman? So again, these are the guidelines recommendation that inositol in any form should currently be considered as experimental therapy in PCOS with emerging evidence on efficacy highlighting the need for further research. But in our day-to-day practice, as it has a very high safety level quotient, we all are giving as an empirical therapy the myoinositol to these type of women. It is one of the therapeutic alternatives which has recently been investigated. It definitely improves the metabolic profile of PCOS patients. There are 9 different stereoisomers of inositol and D-chiroinositol is the second common isomer. Administration of D-chiroinositol has been proved to reduce insulin resistance, and some studies report that the dose needed is 1 gram D-chiroinositol plus 400 microgram of folic acid per day to reduce the metabolic syndrome and to increase the glycemia insulin ratio. So if at all you want to prescribe, you should know which dose and what combination to be prescribed to this category of women. Now coming to the psychosexual function. All health professionals, they should be aware of the increased prevalence of psychosexual dysfunction and they should consider exploring how features of PCOS, including hirsutism and body image, is impacting on her sex life and her personal relationships. If psychosexual dysfunction is suspected, there are various tools such as the female sexual function index which can be considered. But as a clinician, first you have to be aware of this entity. Now, should you do tubal patency test in each and every case of this PCOS and infertility? The guidelines are recommending tubal patency test for women with PCOS due to anovulation alone. With normal semen analysis, you have to consider the risk, benefits, cost, and timing of patency should be discussed on one-to-one basis. It should be considered prior to ovulation induction in women with PCOS where you are suspecting tubal infertility. So it's not a must that you should do a tubal patency evaluation in all these women. Now, once you have done all these things, then you have to proceed for the ovulation induction. Don't jump to ovulation induction the moment you see a case of PCOS and infertility. Now, what are the ovulation induction principles? Because they are having irregular cycles, remember to exclude pregnancy prior to your ovulation induction, prior to giving them withdrawal bleeding so that you can start your day 2 ovulation. Unsuccessful, prolonged use of ovulation induction agents, they should be avoided in these cases due to poor success rates. So these are the first line management: letrozole, clomiphene, metformin in combination with CC and letrozole. Letrozole, it should be started in a dose of 2.5 to 5 milligram from day 2 onwards. You have to start monitoring from day 8 onwards, and there are definite advantages of letrozole over clomiphene citrate in the form of there is no anti-estrogenic effect on endometrium and cervical mucus. You have a monofollicular development and there are reduced chances of OHSS and multiple pregnancy. Clomiphene citrate again should be started from day 2 if at all you are planning to start clomiphene. The maximum dose you should never exceed beyond 150. Follicular monitoring is same as that of letrozole. And how many cycles? With oral ovulations, I will say not only clomiphene, with oral ovulations, the optimum chances of her becoming pregnant is first 3 to 4 cycles, and you should not do more than 6 cycles of stimulation with these oral ovulations. So when to stop should be known to each and every clinician. When 6 ovulatory cycles fail to give you a pregnancy, there is no ovulation with highest permissible dose, and when endometrial thickness remains less than 7 millimeter, you should stop your ovulation induction protocol. When to add metformin to these agents? When those women who are clomiphene citrate resistant, where BMI is more than 25, and here the aim of adding metformin is to improve ovulation and pregnancy rate. Can you give metformin alone as an ovulation induction agent? Can be given in women with PCOS. However, we don't prescribe it on a standalone basis. It is always combined with CC or letrozole. When you are adding metformin, you should be aware of the following points, that is the GI side effects. For these you have to start it in 500 milligram increments, and this increment should take place 1 to 2 weekly time. Metformin does cause low vitamin B12 levels, so should be aware of it, and it is generally a off-label drug. Now we are having sustained release formulations available which give less GI side effects, so prescribe metformin SR formulations. Now coming to the second line. Second line is gonadotropins or laparoscopic ovarian relay. When to start second line? For those women who fail to conceive with the first line. When gonadotropins can be first line? See, here I am saying second line, but gonadotropins can be your first line therapy in these PCOS women where it is available and affordable, where there is presence of ultrasound monitoring, and where following counseling on cost and potential risk of multiple pregnancy. When you are thinking of gonadotropins as your ovulation induction agent, you should consider the cost, availability, expertise required for use in ovulation induction, degree of intensive ultrasound monitoring required, risk and implications of potential multiple pregnancy, and risk of OHSS. Now market is flooded with so many preparations of gonadotropins. So which gonadotropin? Whether you should use HMG, highly purified HMG, urinary FSH, highly purified FSH, or recombinant FSH, there is no difference. You can simply go ahead and use HMG for your PCO woman. What should be your starting dose? It depends on the age of the woman. Antral follicular count, which you all should learn. You should do your own day 2 transvaginal scan and antimalarial hormone levels. If she has already undergone gonadotropin cycle, then what was the response in that previous cycle should also be taken into consideration. Just to simplify your life, this is the starting dose for non-IVF I am talking. So it can be started if she is less than 35, non-PCO 150, and if she is PCOS, you can start with 75. But if she is more than 35 years, you can have your starting dose of gonadotropins as 150. Now, how to monitor is a big question. So how you are giving gonadotropins? Starting from day 2. Day 7, you have to call her for transvaginal ultrasound for the dose adjustments. And what you are looking on day 7 transvaginal ultrasound, you are looking for follicles of more than 10 millimeter. If there are 2 to 3 follicle, same dose. 4 to 6 follicle, you can continue with the same dose, or you have to taper. But if there are more than 6 follicles, do taper and look for OHSS. But if their follicles are less than 10 millimeter cycle, you have to increase the dose. When the lead follicle is 18 millimeter, you have to trigger for ovulation. Many would like to combine oral ovulogens with gonadotropins. So how to go ahead with it? From day 2, you have to start your oral ovulation. From day 5, you have to add gonadotropins, and from day 7 onwards, you have to continue monitoring as I showed you in my previous slide. When you are monitoring, don't look at only the follicular size. You have to monitor the endometrial thickness as well. So the number and size of follicles and pattern and thickness of endometrium should be monitored. When to give trigger? If it is an oral ovulation cycle, then the follicle size should be between 20 to 22 millimeter. If it is a standalone gonadotropin cycle, the follicle size is between 18 to 20 millimeter. You can give trigger. What should be the dose? 5000 IU of SCG is sufficient as a trigger dose in these women. When not to give trigger is also very, very important. When you are seeing 3 or more than 3 lead follicles, you should not give trigger. You should write and document on file that this cycle has been cancelled and advise abstinence to these couples. Now don't forget the luteal phase. When it is a oral ovulation cycle, it is empirical. We all are giving empirical, but evidence is telling us that luteal phase support is not mandatory in cases of oral ovulation cycles. But if it is a gonadotrophin stimulated cycle, then yes, luteal phase support is a must. So you have to give luteal phase support. Various drugs are available. We have oral, intramuscular, or vaginal. It depends, but we do prefer vaginal route of progesterone support as a luteal phase support in majority of the cases. Now coming to the PCO drilling, which is a second line management in these women. This is a surgical solution for a medical problem. It reduces hyperandrogenism and improves the intraovarian milieu, but it lacks standardization in terms of indications, modality, and follow-up. Which PCOS woman will benefit from PCO drilling? It is best for those women if they are having infertility duration of less than 3 years, they are thin, lean with high LH levels. Although it has been utilized for decades, the technique has never been standardized regarding the energy source, number of punctures, dose and duration per puncture, whether one or both ovaries should be treated. But based on limited dose ranging studies, 3 to 6 punctures per ovary at 40 watt setting for 4 seconds per puncture seems reasonable. When LOD can be considered as a first line in these women? It can be considered as a first line if anyway laparoscopy is indicated for another reason. Risk should be explained to all women with PCOS considering laparoscopic ovarian surgery, and all lap for infertility should always be combined with hysteroscopy. So these are the advantages of laparoscopic ovarian drilling over gonadotrophin stimulation, and there are disadvantages as well. Now coming to the third line management. Again, you have to consider the availability, cost, convenience, increased risk of OHSS, insufficient evidence to recommend specific FSH preparations. Here also you can safely go ahead and use HMG preparations, and exogenous recombinant LH should not be routinely used in combination with FSH. Which protocol? It has been fairly standardized now. For all these women of PCOS, if they are undergoing IVF, it has to be an antagonist protocol, agonist trigger, and freeze-all embryos, so that we all are having now OHSS free clinic for all our IVF cycles for PCOS patient. But OHSS can occur in cases of oral ovulations and in gonadotrophin cycle as well. So each and every clinician who is managing these women should know about the OHSS, not only IVF and ART clinicians. You should know about the early OHSS and late OHSS. Early presents 3 to 7 days after HCG administration, and late OHSS presents 12 to 17 days after HCG administration. Prevention is better than cure. IVF, we are very much comfortable with our protocol, antagonist protocol, agonist trigger, and freeze-all embryos. In your IUI cycles, you have to avoid HCG. I have already told you when not to give trigger. Be liberal with cancellation of cycles. Now here your duty does not end. You should remember that maternal these cases in pregnancy, they have increased prevalence of early pregnancy loss, as Tofu has already highlighted, gestational diabetes, pregnancy-induced hypertension, and small for gestational age babies. Now, even after giving her a healthy baby, your responsibilities don't end, because you have to counsel her about the late sequelae. She is 7 times more at risk for diabetes mellitus, 4 times more risk of hypertension. She is more prone for dyslipidemias and 3 times more risk of endometrial cancer. So friends, to summarize, first and foremost is lifestyle management, optimize BMH, Then only start with the first line management, that is oral ovulagens, second line gonadotropins and laparoscopic ovarian drilling, and third line is IVF ICSI. Don't forget the special care which they need during pregnancy and the late sequelae as well. Remember, it is not what you give, it is the way you give it. So thank you. Thank you so much for your patient hearing. And if there are any questions, I am more than happy to answer it.